honor Dr. Charles Smith, who's also in the audience. Before that, a couple of announcements. Number one, as you know, I always give a couple of announcements before grand rounds. And I was just informed that Dr. Mark Breyer was born on this day back in 1959. So you need to know that.
Future Nobel Prize winner.
There you go. But more important than that, I wanted to know if Ruth Carrico is here. The ID group maybe, I don't know if they're somewhere here or not. But Ruth Carrico, who just joined the Department of Medicine a few months ago, has just been named the 2012 recipient of the prestigious Carol DeMille Achievement Award by the Association for Professionals in Infection Epidemiology. And Ruth has been working for 20 years in infection control and prevention. They're called preventionists. I have not heard that word, but that's sort of interesting. If you see Ruth, tell her congratulations. It's a well-deserved honor. This is going to be announced at the annual meeting in San Antonio later this summer. So congratulations to Dr. Carrico. So it is on location that I have the privilege of introducing an endowed lectureship, but it's even more rare for me to be able to introduce an endowed lecture with the honoree sitting in the audience, still very active and still very much beloved by the people who surround him. And that is the thing that makes this exciting today. And we're here to honor the work of Dr. Charles Smith, who's sitting right here in front of me. So a couple of things about him and telling you a little bit about what was happening at that time. He was born in 1930 in Bell County, Kentucky. 1930. Now you may say, what was going on back in 1930? Well, it turns out that just 5 years before that, there was a young woman called Cecilia Elena Payne at Harvard in her little postdoctoral dissertation trying to convince people that she knew exactly the composition of the sun, that it wasn't the way people thought about, that it was iron about 65%. She said, no, it's iron 1%. It's mainly helium. The universe is this way. She was using atomic laws to define all of this. Nobody believed it. She couldn't convince her supervisors. It took another 20 years for Fred Hoyle to actually define that she was completely correct. Just 5 years after Dr. Smith was born, there was another man called John Gibson who was able to maintain a cat alive in a heart-lung artificial device that he had created. It took another 18 years for this person to make a better device and finally have an open heart surgery in an 18-year-old patient. I suspect that these things, plus the interest that Dr. Smith had in taking care of the ill in Kentucky, that attracted him to medicine. And so he went to college at Georgetown and then came back to the University of Louisville to obtain his MD in 1955. And I understand that's when you married Rosemary. So, which we had dinner last night with them, and it was wonderful. And so he did a rotated internship in Alabama, but then got detoured a little bit to become a flight surgeon in the U.S. Air Force. And he was in San Antonio from 1956 to 1958. He comes back to do his medical residency at U of L, and he becomes chief resident here in 1960. He works after that as an attending physician at Methodist Evangelical and becomes a significant leader in that organization. And he raises through the ranks here at University of Louisville to become clinical professor of medicine in 1985. And for years, he's known as the doctor to the doctors until he retires, if you could call this retirement, in 2001, because he remains quite active. He's had a number of awards, and I don't have time to describe them all. I'm just going to mention a few. In 1987, he was named Alumni Achievement Award from Georgetown College. He was scientific editor of the Kentucky Medical Journal in the 1960s. He was president of the Jefferson County Medical Society in the 1970s. He was president of the Nominate Society. He was chairman of the Louisville Society of Internists. He was president of the Kentucky Medical Association in the 1980s. He was governor of the American College of Physicians, vice chair of the board of the directors of the Kentucky Blue Cross and Blue Shield in the 1990s, and I could go on. So at some point, an executive director of the Greater Louisville Medical Society was asked about Dr. Smith, and he said, Charles Smith is revered by patients and colleagues alike for his intellect, phenomenal memory, and ongoing service to patients in our community. That, my friends, is why we honor Dr. Smith today by bringing a special guest from the outside, as we do every year, to let us know what's happening in an important area of medical diagnosis and treatment. So I leave you now with Dr. Barbara Casper, who's going to introduce our guest speaker of the day.
I'm very pleased to be able to introduce today's speaker who will present the Charles Smith Lecture. Today's speaker, Dr. Diane Schneider, received her undergraduate degree from Wake Forest University and subsequently obtained a master's in education from the University of Kentucky prior to completing medical school at the University of Louisville. And she graduated from medical school with Dr. Parker and several other internists that are in the community. She received her residency training in internal medicine at Emory University, followed by a fellowship in geriatrics there. And after 2 years as a faculty member there, she became an assistant professor of medicine at the University of San Diego, from which she has subsequently retired. Dr. Schneider's academic interests included her career have been bone health and osteoporosis. And I want to focus, as she very generously presented me with a copy of her book on the complete book of bone health, which has a foreword by Sally Ride, which is pretty interesting. She has published numerous articles and has served on the editorial board of numerous journals. She's been named one of the 10 national thought leaders by the American Geriatric Society and is recognized as an expert in bone disease. She is active in the American Society of Bone and Mineral Research and has served as the Society's representative to the National Osteoporosis Foundation. And more recently, she has written the book that I mentioned, and is co-founder of For Bone Health, an organization to increase awareness and education of bone health for all ages and stages using social media. I had the pleasure of having dinner last night with her and also learning that she water skis in the Bay of LA, which is apparently not legal, so don't try it. And we are delighted that Dr. Schneider has joined us today to deliver the Charles Smith Lecture, and she will speak about atypical fractures, a long-term complication of bisphosphonates. Dr. Schneider.
Thank you very much for your kind introductions, and it's really wonderful for me to be back in what I consider my medical home, and certainly a great honor to be giving the Charles Smith Jr. Lecture. And certainly as a third-year medical student, we lived in fear of Dr. Smith, but now certainly I've come to as well revere him. Certainly, right now this is certainly a hot topic in terms of how we take care of our patients with osteoporosis. And I want to start out by introducing the topic by really going to another Diane, who is a native from Louisville. So to start out with,
the World News investigation. Last year, more than 37 million prescriptions were written for medications like Fosamax to fight or prevent osteoporosis. Many people stay on them for years and years, but for weeks now, Dr. Richard Besser has been looking into reports that in some women and other people over time, the drugs weaken certain bones, and he is here now with his results. Rich, what did you find?
Diane, no question that Fosamax and other bisphosphonates are valuable drugs. In the right women, they can prevent hip fractures, which can be deadly. The use of these drugs, however, has skyrocketed. We've been hearing about women having unusual breaks in their thigh bones. As I looked into this, I was shocked by the lack of attention this has received by the federal government. Sandy Potter was jumping rope with neighborhood children when it happened.
I went up in the air and came straight down to the ground.
Take a look at this. Her femur didn't just break, it literally snapped in two.
The pain was excruciating.
She began taking the osteoporosis drug, Fosamax, at the age of 48. She'd been on it for 8 years.
okay, well, certainly my phone started ringing off the hook, and I'm sure many of you who take care of patients who are on these medicines also were running off the hook. And I got immediate call, I think within 2 seconds of that being off the air, going, Dr. Di, what, should I get off the medicine? What should I be doing? And certainly from that one thing, which was then repeated at Good Morning America the next morning, and then, all the media blitz certainly took off, that women who are on, particularly Fosamax, which is alendronate, were stopping the medicine certainly left and right, and really thinking that here I'm taking this medicine to decrease fractures, and look what's happening. And so the viewpoint of people were really of this, having terrible fractures. And certainly right after that was the lawyers as well, looking at that and following that sort of line. But really, what is this all about? And is it true that what we're seeing here is something that's related to long-term bisphosphonate use? And really, how common is it? So what I really want to go over is, first of all, to define what are these atypical femur fractures, who's at risk, sort of give you the epidemiology look of how this sort of evolving story has happened, and it really continues to evolve. Do we really know what the cause is, and really what should you be doing as a clinician? So first of all, in terms of starting out with the definition, to look at in terms of the femur itself, and the red area that I've gone through, this is the whole diaphysis, which really is taking into account the subtrochanteric region along with the femur shaft. And so any fracture that's occurring in that area is what we're referring to, but it has a certain type of characteristic. So I'm going to differentiate between what we call the typical osteoporotic fracture, which is on the left, versus the atypical, which is on the right. Now, in terms of the typical osteoporotic femur fracture, I'm looking for a pointer. In terms of, we have a very thin cortex, and usually what's happening with the fracture is that it's usually in a spiral. It's unlikely for it to be bilateral, and it's more sort of shattered in pieces. Where we're saying in terms of the atypical, it's more like chalk breaking, and you have a straight across transverse fracture, and then have what they call a beak, this little medial spike. And it's not unusual for these to be bilateral. And along with this, that there is on the lateral side this cortical thickening that you don't see in terms of in the typical osteoporotic fracture. Now, if we, in terms of looking at this, that the orthopedists sort of gone through and staged this, because this is not something that just automatically happens. There's really a natural history that's occurring. So first, in terms of what's termed stage 1, is we're getting this thick lateral cortex. And for the individual, that many times there's pain associated at this time frame. If we do a little closer up in terms of the middle, that there is actually these very thin horizontal lines that you may see as well. Then if we move in terms of looking at another picture in terms of just sort of this exuberant, thick cortical thickening that you don't see with a typical osteoporotic fracture. And then in terms of, this is an example in terms of showing sort of where it happens bilaterally, and then you get a little bit of what's called actually beaking in the area where there's a localized periosteal reaction that's usually happening where you see those thin lines. Then if we move into in terms of stage 2, where you actually have what we consider as an incomplete fracture. And some people have termed this, well, is this a stress fracture or really what's going on? And if you look in terms of very closely, that you can see that this is the area that then there's this dark line, and then that is where it extends from then all the way across to the medial cortices. So this is really an incomplete fracture that goes on and goes to the completed fracture, which is the stage 3. Now, in terms of how these are fixed, that they use an intermedullary rod. And these tend to have problems in terms of healing. And with that, it's very slow, and that the fracture may actually be visible on X-ray for a very long period of time. And about 20 to 25% of these people have gone on to have a bilateral fracture. But interestingly, that we know that with an osteoporotic fracture, that there's a very high percentage in terms of death, with 1 out of 3 men, and about 1 out of 4 to 5 women die within a year for a typical osteoporotic fracture. But with these fractures, because they seem to be happening in younger individuals, there's actually a very low death rate. So here's just an example of about 6 months post-operatively, you can still very clearly see where the fractures occurred. So you have they tend to have very slow healing. So if we sort of look at what this evolving story is and look at what are the bisphosphonates, so the first bisphosphonate, alendronate, or brand name Fosamax, was approved in 1995. And then subsequently we have Residronate in 99, 2003, Abandronate, Boniva, the so-called Sally Field drug, and then in 2007, Zolendronate, a reclass, which is given as an IV once a year. And so in terms of, in 1995 was the first bisphosphonate, and it was in the early 2000s when there was first perhaps a clue in terms of the evolving story that something might be going on. And the very first case report was actually in 2005, and it was a series of 9 patients who had come to the Henry Ford or the UT Southwestern Medical Center. And out of those 9 patients who were treated with alendronate, that what caught people's attention was that these occurred without any trauma. And out of the 9 cases, that 5 had femur fractures, and 3 of those occurred in the femoral shaft area, and 2 of which were bilateral, which was, again, rose some interest because this is not what you typically saw. In addition to being on alendronate, 2 of the individuals were on prednisone chronic therapy, and 1 was on estrogen. And of these individuals with a femur fracture, 3 had delayed healing, and then all the individuals, interestingly, were continued on alendronate because at that point there was no clue that there may be something related. And bone biopsies were done anywhere from 1 month to 12 months after the fracture, and that's where they determined that there was quote-unquote suppressed bone turnover, at least in these group of individuals. So in the case report, they really reported that these were complications or potential complications of alendronate therapy. Now, it wasn't until 2 years later that the next case report came out of Singapore, and this was just of subtrochanteric fractures. And with this, there were 13 patients who had low energy fractures. 4 of whom had no exposure to alendronate, the other 9 being on it for about an average of 4 years. What was interesting is those individuals on alendronate, that the average age was 67 versus the ones who had no exposure was 80 years. And 5 of the 9 had some sort of prodromal pain. In terms of looking at what was associated with the fractures, 4 had no falls and 5 had low energy fall or trip that seemed quite insignificant. And looking in terms of at the x-rays, that 6 had this lateral cortical hypertrophy, and 3 had changes on both sides. So this was really the first report that sort of characterized what then we've gone on to call the atypical femur fractures. And then subsequently, over this next couple years, there was sort of this emerging common x-ray pattern, again with the transverse fracture and the cortical thickening, and they were called sort of a simple, almost chalk-like fracture. Then after the case series, then moved on to looking at cohort and case control studies. And with this, Abrahamson looked at all the individuals in Denmark for 1 year who had been on any type of bisphosphonate therapy, and actually they were all on alendronate. That was the available drug. And with looking at epidemiologically, they really did not find any difference with the subtrochanteric or diaphyseal fractures than those that are happening in the trochanteric, intertrochanteric area of femoral neck in terms of the classic osteoporotic fracture. And so the conclusion in terms of epidemiology-wise was not really finding any signal that there was something different with the individuals who were taking alendronate. Also in Sweden, a similar analysis in terms of epidemiology looking at 1 year time frame, and really only finding 2 people that had femoral shaft fractures who were not on bisphosphonates, and 3 individuals, and this was out of 89,000 women who were included in the registry. On the other hand, in terms of not taking an epidemiology look in terms of a large population, but in terms of who was showing up for the orthopedic surgeon from the Hospital of Special Surgery in Cornell. There was a look taken from the previous case series and looking in terms of all of the individuals who came in for femur fractures in terms of in that area. And they found that actually over a time period of approximately 7 years that there were 41 individuals who had come to the Hospital for Special Surgery in New York with these type of fractures, and 10 of those individuals had been treated with alendronate. So if you asked the epidemiologists who are counting numbers, they're really saying, well, we really don't see much of a difference. But if you had the surgeons who were taking care of the patients, they were saying, look, we didn't seem to see these things before the year 2000. And now, about 5 years after people have been taking alendronate, that we're actually seeing these unusual fractures. So, you know, who is really right? So this really leads us up to the story in terms of that I showed you at the beginning in terms of ABC, and that what we're having in terms of the media impact. So what happened was that in March 2010, the orthopedist from the Hospital for Special Surgery had an abstract presentation for the American Academy of Orthopedic Surgery, along with there was another case presentation having to do with these type of fractures. And prior to the orthopedic meeting, that this was picked up by the media, and as you saw in terms of creating a tremendous amount of information. Well, of course, originally the FDA were sort of caught flat-footed, and 2 days after the ABC story came and said, well, you know, there really has not been any clear connection, and cited the Abrahamson study in terms of looking at the Danish population. So what they actually asked was, they went to the experts at the American Society for Bone and Mineral Research and said, you know, can you take a look at this? And so a task force was put together, and 6 months later, then a report was issued about this. And one of the big things was just trying to define what are these fractures, because different people are calling different things. So really, the one goal was to look at to come up with a case definition, to review all the available data, to sort of get an idea of how many fractures are really have happened. What is the relationship in terms of with bisphosphonates, and in terms of looking at where do we go from here? So in terms of definition, that it was defined first of all in terms of major features. So first of all, in terms of the location. The second, that it was not having to do with any significant trauma, and describing in terms of, again, the straight across, the transverse or short oblique configuration, that it was not in parts, so to speak, and that it could either be the complete fractures you're seeing in the picture, or what we referred to earlier in terms of stage 2, in terms of an incomplete fracture. Now, all 5 of these criteria must be met for the diagnosis, but also look in terms of that 4 out of the 5 have to do with what the radiograph actually shows. And so many things in terms of looking at these fractures, to be aware that if they're looking at ICD-9 codes or just the X-ray reports, that's not enough. You really have to look at the X-ray themselves. In addition to these major features, also they came up with having to look at minor features. And with the minor features, here's where, in terms of looking at that localized periosteal reaction with a little bit of the beaking, the increase in terms of the cortical thickness, particularly on the lateral side. Historically, in terms of prodromal symptoms, particularly dull or aching pain in the groin or thigh, and that the possibility in terms of bilaterality to this with both symptoms and fractures. After fractures occurred, in terms of delayed healing, and then that in terms of looking at the cases that we reported, that there seemed to be a higher incidence in terms of other comorbid conditions, as well as other pharmaceutical agents in addition to the bisphosphonates, such as steroids and even proton pump inhibitors. So the ASBMR tried to look in terms of how many cases actually not only in the United States, but internationally. And actually, they were able to come up with a total number of 310 worldwide in 2010. Now, part of this has to do with, in terms of definition, and they wanted to also have X-ray adjudication for all these. Out of the 310, 286 were actually on bisphosphonate therapy for the diagnosis of osteoporosis. And the largest case series was out of Kaiser in California. And I'm going to present sort of that series because it sort of gives you a good depiction of what the patients are that presented with these. So first of all, in terms of Kaiser is divided up in California in terms of Southern California and Northern California, and it's an integrated health maintenance organization of which they have a pharmacy database, and the majority of the individuals, 99.9% actually get their medicines all filled through the pharmacy. So they have a good way of tracking in terms of the whole integration of diagnosis and treatment. So for over a 3-year time period, they reviewed all the fractures that had come through, and showing you what a tremendous number in terms of a base of people that they have in terms of population. But there were over 15,000 femur fractures that occurred, and they reviewed all of those that occurred in the diapicell region. And looking at the x-rays that they identified, out of those, a little less than 10%, 135, were designated as the atypical femur fracture. So from there, in terms of characterizing these individuals, that they were predominantly female, with an average age of 71, and they did have a history of prior fracture. And the Kaiser system, that in order to get a prescription for alendronate at that period of time, they did not do any prevention. You actually had to have, either at the hip or the spine, a DEXA score of minus 2.5 or lower. So these people indeed did have, were being treated for osteoporosis. Their BMI, however, tended to be a little bit higher than some of the little skinny ladies that we talk about being at higher risk. And for those that had a DEXA available, interestingly, the mean total hip T-score was minus 2.2, but they don't give us in terms of what the lumbar spine T-score was. And there was a 2% death rate within the year after the fracture. Now, this is just showing in terms of the age distribution that did go from quite young, from 45 up to over 80, with predominantly being in the 60s, with the average age again at 71. And this is very interesting in terms of the race and ethnicity. So 44% of the individuals were Asian, although in the Kaiser population, about 10% of the population is Asian. And then 45% were Caucasian, 11% Hispanic, and no African Americans. About 2/3 of the individuals did have some sort of pain complaint, and the pain complaint could have been for a long period of time, and I'll show you later a case from them where actually someone had been complaining for and getting regular medical care for 18 months. 1 in 4 of them had bilateral fractures that maybe not necessarily occurred at the same time, but within a time frame. And that although the first characteristic, as this was characterized, was subtrochanteric fractures, only 40% occurred in that area and 60% occurred in the shaft area. In terms of bisphosphonate use, interestingly, 5 of those individuals who had the characteristics of these atypical femur fractures had never had any exposure to bisphosphonates whatsoever. And 92% of those had exposure to bisphosphonates within the previous 1 year. And the average length of use was 6.3 years, but on this you can sort of see that there was a wide range in terms of the length of use, with, yes, some people just having for a short period of time sustaining a fracture. In terms of looking at age, which is the length of use, there really was found to be no relationship in this group at all. And if they, in terms of trying to figure out in terms of what sort of is the incidence rate, what they did was look at the exposure of bisphosphonates, went to their pharmacy database and looked at how many people over this 3-year time period were taking bisphosphonates. And you see here in terms of less than a year, this is very typical in terms of treatment for osteoporosis, and probably you can say this for any chronic disease, that although someone is prescribed a medicine, there's a very poor adherence to the medicine, and less than 50% of the individuals continue after getting that initial prescription. So it was estimated that approximately about 35,000 individuals each year were prescribed, got a prescription for alendronate, was what the bisphosphonate of choice was for the Kaiser patients. And that a very small number in terms of out at 12 years, and at 12 years these individuals would have been started like in 1995 when the original drug was FDA approved, and only about 1,200 people ended up in terms of once they got out to 12 years. However, when they looked at the relationship between the length of use and the numbers of people, that they actually saw that in terms of duration of use, the quite marked increase in terms of those who were exposed to bisphosphonates a longer period of time, and so that once you got to the average time period in terms of at 6 years for these individuals, that it was estimated about 100 individuals per 100,000 would be sustaining these type of femur fractures. But again, remember that the total number we're talking about here was only 135 individuals, 5 of whom did not have exposure to bisphosphonates. So once the ASBMR task force report came out and was submitted, and the FDA had time to look at what they had reviewed and defined, that what they basically did was in 2011 institute a labeling revision. So now in terms of in the label that they added that the optimal duration of use has not been determined, and the need for continued therapy to be reevaluated on a periodic basis. And a lot of this has to do with sort of the movement from using these drugs for both prevention and treatment to really targeting the individuals that are high risk for fracture rather than using these for prevention, as well as evaluating that once someone perhaps has moved up into the so-called osteopenic range out of the osteoporotic range in terms of T-scores to reconsider in terms of does this individual still need to be taking the bisphosphonate. In addition, that anybody that has a complaint in terms of thigh or groin pain, that this really needs to be evaluated and to look at in terms of is there any underlying problem that may lead to an atypical femur fracture. Now, after the ASBMR report came out, that there was actually a big rush to take a look at how common are these fractures. And so using an inpatient sample from ICD-9 codes, that this study was put together showing that, as we know, that the overall, in the left-hand panel, the overall number of hip fractures is actually declining over time. What was shown in the right-hand panel was that over time that actually the number of subtrochanteric hip fractures increased. But of course, the caution here is that looking at this type of epidemiology evidence, that first of all, there's no specific ICD-9 code that differentiate between a femoral shaft fracture that's a typical osteoporotic fracture versus an atypical finding. There's no radiographic adjudication, and we know that in terms of actually saying that this is atypical, you really need to look at the x-ray. And indeed also that there was a relook in terms of at the major clinical trials, such as the Fit and Flex trial, which used alendronate for up to 10 years, and also the Horizon trial, which uses the zoledronic acid, and to see whether or not any atypical fractures occurred during those studies that were not previously classified. And unfortunately, of the 6 fractures that were found in those groups, that they only had X-ray reports. There was no way actually to adjudicate whether or not that those were atypical versus some other type of fracture. So in terms of trying to get a better handle on how common these are, the Kaiser group in the Northwest had electronic records going back to 1996. So they actually screened using ICD-9 codes and then pulled out X-rays. And what they showed over the time frame in terms of incidence rates, again, in the upper panel showing a decrease in terms of the typical femoral neck, intertrochanteric, and total hip fractures. And at the bottom, at a different scale, showing subtrochanteric or femoral shaft fractures. And again, there's a very small number, and those actually seem to be steady. There was not really any increase. It was shown in the previous ones. And then what they did was take a look at the X-rays that were available from those individuals and found that there were 75 that were classified as atypical fractures. And what was interesting, that in the first group of it, they found that only 66% of the radiographs actually had the accurate ICD-9 codes for the femoral shaft. And in the individuals, in terms of in the blue line of the top, in terms of the atypical fractures, were divided in terms of those who met the major features, so those 5 features that we talked about, 4 that were radiographic and 1 that it was just atraumatic in the blue. And of those, there were 53 individuals, only 16% had some exposure at some period of time to bisphosphonates. Then in terms of the red is showing atypical fractures that met both the major features and the minor features as defined by the task force. And there were 25 individuals. And so there's a little signal up in 2000 when the first fracture that you saw both the major and minor features were shown. And then it really, because there was such a few number, that it was pretty constant across that time frame. So in terms of looking at a small population, and those individuals in terms of the red, 66% of those had ever had exposure to bisphosphonates. So this is in terms of a good example in terms of a population that's going to a healthcare system where there seemed to be a signal up about 5 years after the alendronate was first FDA approved, and then a pretty constant rate in terms of after that. Now the best study so far was just published last year in the New England Journal of Medicine in terms of epidemiology and reviewing all of the women who were 55 and plus the 1 year of 2008 in Sweden and looking in terms of the fractures. And they looked then at data for use of bisphosphonates for the 3 years prior to that. And again, this is actually very similar to what we saw in terms of the numbers of fractures, similar to the Kaiser California data. So out of the little over 12,000 femur fractures that occurred, that they found about 10% were in the diaphyseal region. And they reviewed the majority of those and found that 59 of those met the criteria for atypical fractures, and 78% of those had been on bisphosphonates. Then taking this data, then they went and looked in terms of the incidence rates to give us a little bit better idea, because you can certainly do this more with a population. And what was found was in terms of those individuals who had ever been exposed, that if you look at the far right-hand side, the age-adjusted absolute risk was 0.0005. So we're talking about a very, very small risk. Now, the limitation of this study was that they were only able to look at use up to 3 years with bisphosphonates. But you do see in terms of duration, in the second area, in terms of for 2 years or more, being a little bit higher at 0.008. But again, we're talking about quite unusual and classified really as a rare event that's occurring. And what's also very fascinating was in terms of looking at time since last use. And finding that once you're off of the bisphosphonate for a year, that there's a marked decrease in your risk. So if you look at the relative risk in terms of this, it markedly goes down 80% from 42.9 relative risk to just 3.5. And this has been actually shown from the Kaiser data that was just presented last month, an orthopedic abstract, again showing that after 1 year of use or being off of it, that there was a reduction of 70% in terms of risk. And no one can really quite explain in terms of why that might be happening quite rapidly. So what is really causing these? Is it bisphosphonates? Is it something else? What's really going on? And are these truly new fractures? So this is from the archives of the Wellcome Trust in Britain, showing a femur that was excavated in Palestine and estimated to come from about 100 BC. And this very clearly shows a healing transverse fracture across the femoral shaft. So indeed, these are not new, and there has been prior epidemiology studies in terms of showing these types of fractures, but how are bisphosphonates perhaps related to this? And there's a whole variety. I certainly don't have the answer, and there's a lot of different proposed causes. So number one is just a simple biomechanical. Others have to do with altered mechanical properties that seem to increase the bone's brittleness. Or is there something genetic that's going on because some of the childhood diseases have a similar type of chalk-like fracture that occurs? So we first look at in terms of biomechanical. One thing that the orthopedic noticed that some of the individuals, particularly these Asian women that Kaiser had, that they have more bowing of their femurs, and talk about in terms of biomechanically the amount of stress that it's put right where the bowing occurs is quite high. So is there something going on in terms of with that, because that's where, in terms of the fracture occurs, this was 2 months after that previous fracture, that's where the fractures are occurring. However, just published a month ago that in Denmark they took a look at all fractures occurring in another shaft bone. So they looked in terms of the humerus and said, is this bone, which is similar to the femur, is this same type of fracture we've seen there? And interestingly, that they found 20 fractures that they classified then in terms of atypical fractures versus ordinary. And as you can see for these on the two left-hand panels, that these look very similar to what we see in terms of the humerus. And certainly, we are not walking around on our arms, and so this is not a biomechanical thing that's happening. Also, interestingly, with these humeral shaft fractures, that of the 4 that were atypical, none of them were exposed to bisphosphonates, so you're seeing a very typical features that you saw in terms of on the femur, and that 1 out of these 4 were on steroids, another 1 was diabetic, but clearly they had the cortical thickness and the same looking type of fracture that we saw in terms of the classification of atypical. So biomechanical in and of itself really does not give us a full picture in terms of what's going on. But where most of the debate has to do with it in terms of this altered mechanical property. So is there truly oversuppression of bone turnover, as Odiva, who gave the first case report, said in terms of the bone biopsies? Well, there's been other studies that have done bone biopsies in individuals who had these atypical femur fractures and have not shown the same thing. If you look at bone turnover markers in these individuals, bone turnover markers were not lower than they should be. Of course, the bone turnover markers were being taken after the fracture had occurred. What we know is that it probably is not a generalized problem with lowering bone turnover to the point that you're making brittle bone, but certainly in terms of where the localized effect is definitely nothing is going on in terms of bone remodeling or bone turnover there in terms of where the fractures are actually occurring, and that's one problem in terms of the healing of these fractures after they have occurred. So one other question in terms of, is this accumulating what they call micro damage, so that we know in terms of normal bone remodeling that the thing that starts the bone remodeling is something called a micro crack. And then with the bone remodeling that you get that area repaired. And since you were lowering the bone turnover with the bisphosphonates, are you making areas not getting repaired, and so that the micro damage, so to speak, is building up? Well, the data for that really is shown from, again, biopsy data up to 10 years with using alendronate in the FLEX trial, was showing really normal bone biopsies. Another theory is that you're losing something called heterogeneity with the bone. And it's sort of like thinking about a surface that used to be quite irregular, and now it's somewhat like ice or glass, and it's very easy to break and brittle. Now the problem is it's very difficult in terms of, in the human model, looking at this, and they've used beagle dogs as models and really have not found that as a problem. One of the latest theories is something looking at increased advanced glycation end products, are called AGEs. And this is one area where having to do with actually the sugar metabolism with the collagen. And this is one reason why they think perhaps actually diabetics are having a higher risk of fracture. Is there accumulation of these that are causing then the bone to be more brittle? Again, it's really difficult to look at humans in terms of this, in terms of, they're looking at it in terms of dog studies, beagle dog studies, and as of yet don't have the answer. And then finally, in terms of what about genetics? All along there's been people saying, well, look at some of the things that we're seeing in terms of these fractures look very similar to what we see in terms of some different things with kids, and also a problem called hypophosphatasia, which has to do with the isoenzymes of alkaline phosphatase. And if those aren't turned on, that there's a difficulty in terms of maintaining the bone, and what you actually get is similar in terms of the lateral cortical thickening and these type of fractures. And so in 2008, actually, Michael White, who's a geneticist at Washington University in St. Louis, presented a case of adult hypophosphatasia who actually looked, the bilateral fractures looked just like we're seeing in terms of with the atypical femur fractures in people treated with bisphosphonates. And so he really brought up the whole idea, is there something underlying here that we're actually turning on, and although someone had not had manifest previously, are we turning on something by use of bisphosphonates? So interestingly, they just presented a case, and then this was published online last month, and they presented a 55-year-old woman who had no problems whatsoever, but was found to have quote-unquote postmenopausal osteoporosis, and was treated with 4 years of sequential different, actually, bisphosphonates. And she presented with these bilateral fractures. And what they found in terms of, in genetics, she had no previous problems that would would make you think at all that she had any underlying problems. And what they think was that the bisphosphonates actually turned on, she was a carrier and actually turned on a problem that she was no longer able to successfully have normal remodeling due to a defect in the tissue non-specific isoenzyme of the alkaline phosphatase. So this is actually sort of an exciting area that I think they're now trying to get gene phenotyping on all these on as many people as they can who have had these type of fractures, and to look to see if this indeed is the underlying problem. So what, as clinicians, should you be thinking about? And really, you need to have an index of suspicion. So is this somebody that's on bisphosphonate therapy? Is your patient Asian with bowed femurs? For some reason, particularly in the Kaiser group, that they had a higher incidence of these things happening. However, if you talk to people at Henry Ford Hospital who have a case series, they go, well, look, all of ours were, Caucasian, Norwegian, Swedish heritage individuals. We didn't have any Asian individuals. If someone has a complaint of hip or leg pain, what you need to do is get bilateral femur steadies from the hip all the way down to the knee to be able to look, because it can happen anywhere in that area. And look at the x-rays yourself, because unfortunately when you get a reading, a radiographic reading of this, is really not giving you the full picture. So here's just an example of somebody who did have a fracture, but 14 months beforehand complained of hip throbbing pain, was sent to a rheumatologist who did steroid injections and was diagnosed with subtrochanteric bursitis. The pain continued, and 3 months before she had a fracture, she had another steroid injection, and as you can see, that she does have the lateral cortical thickening bilaterally, and you can actually see on the left femur, just below the subtrochanteric area, a little bit of flaring of the periosteum, and indeed that's exactly where the fracture then occurred 3 months after the previous one. So that this is not something that just boom happens. I mean, the majority of these people do have some sort of pain, and that you just need to follow that up. So that's the repair, but also there may be things like bone density that may also give you a clue. So this is showing an example over a 5-year period of time where there was progressive cortical thickening of an individual who went on then to fracture, and they went back retrospectively and looked at the person's DEXA scan and said, oh, look, we can actually see it on their DEXA scan. So what should you be doing? If you find somebody that's stage 1, you want to discontinue their bisphosphonate, consider teriparatide for treatment of osteoporosis, monitor their symptoms, and know that in terms of going off the bisphosphonates, that it greatly decreases the risk. In terms of stage 2, once you see that black line occurring that's an incomplete fracture, it's unlikely to heal. They really need to be rotted so they don't go on to complete fracture. In terms of management, remember if someone has one of these fractures to look at the other side. And because if they're getting rotted on one side, they may need to be rotted on the other. You certainly want to discontinue the bisphosphonate and consider teriparatide again and monitor closely, because we know that these people do not do as well in terms of healing. So in terms of the picture of, are these something that are happening right and left? We know that in terms of incidence rates, this still is a very rare event, but we need to be quite aware that there is an associated with bisphosphonates. Make sure that the people that we are treating are at high risk for osteoporosis, and that the people that do have osteoporosis, to make sure that they are being treated, because still that they are much, much more likely to have a typical osteoporotic fracture. And certainly, hips are a deadly fracture, and that's what we're trying to prevent, is the morbidity and mortality associated with typical osteoporotic fractures without harming our patients. So with that, thank you for your attention.
Thank you. That was terrific in highlighting a problem that many of us were not so much aware of. I was going to sort of ask you a question about risk-benefit ratio. Many of these patients are on bisphosphonates because they have a benefit. There's a reason why they're still in the market. So taking them off the bisphosphonates may improve or diminish their risk of an atypical fracture, and yet there's still the concern of the typical fracture. How do I balance that? And WWSFD, you know what that means?
No, I
What
don't.
would Sally Field do?
Well, Sally Field is no longer the Boniva spokesperson, so I don't think she cares anymore because she's not getting those multi-million dollars for advertising. But you ask a very, very good question that actually our patients are asking us as well. And that in terms of risk-benefit, you really want to look at in terms of, are they high risk for fracture? And we like to think about in terms of using the DEXA and the T-score as somewhat of a guidance, as well as whether or not they've had fracture. So that if someone has still a T-score of -2.5 or lower, along with looking at their other risk factors, that they most likely are at high risk for fracture, and that you should consider therapy in those individuals, as well as when they're on continued therapy, even 5 years or longer, they're still in the high-risk group to look at continued therapy. Now, you might want to sequentially use other things as well and cycle them back to the bisphosphonates. But if they've moved out of the osteoporotic range and they're not fracturing and they don't have other things such as high-dose steroids and other things that will put them at risk, those individuals then you may think about discontinuing their drug and then monitoring them on a regular basis.
Thank you. Questions?
So nowadays we know about the prevalence of vitamin D deficiency and its impact on bone and the negative effects of proton pump inhibitors on calcium metabolism. But those things weren't known in 1995 when all of these people started taking the bisphosphonates. So what can you tell us about those practical reversible risk factors and how they might have impacted on this problem?
So certainly vitamin D is one of the most controversial areas in bone in terms of how much, what level. For the individuals that went into the clinical trials, they had to be replete with vitamin D, and at the time that was actually a minimum level of 20 nanograms per ml, which is what the Institute of Medicine now recommends as a target. However, I personally use as a target 30 and higher because I think for bone and muscle, which is the strongest data, shows that should be the level. In terms of proton pump inhibitors, there you want to think about, it's not clear that it's only calcium absorption. It might be something more than that. But using something like calcium citrate, that you don't have to worry about an acid environment in terms of having the calcium absorbed.
Yes.
Given this new data, what's the recommendation for prevention now? Recently it had been used the FRAX score, your tender risk and things like that. Is that changed also?
So what do you do for people who are in the osteopenic, the low bone density range? And so the recommendation is exactly what you're talking about in terms of using the T-score along with looking at the other risk factors. And right now the best tool we have to start with is the FRAX tool, where you're putting in the individual's age, height, weight, family history of hip fracture, previous fracture, whether or not they have rheumatoid arthritis, secondary causes of osteoporosis, alcohol, smoking, and then their bone density. You really need to use that in terms of a starting point from the score that they get. And then if they're at high enough risk with that, which is defined as a major osteoporotic fracture of 20% or higher, to start drug at that point. Of course, you're using your clinical judgment. So for instance, if your patient had a mother who had terrible osteoporosis and was kyphotic, they would actually not show up as higher risk because the FRAX uses, for instance, a hip fracture. Also, in terms of use of steroids with the fracs, it's sort of a yes/no thing. It doesn't take into account, the amount or the duration or anything like that. So you're really using that as a starting point. It's the best we have in terms of quantification of risk. But yes, you're using your T-score along with risk factors.
Yes, sir.
I think the preparation of the bisphosphonate for different risks for the typical femur fractures, like here we go with acid versus
So what about the different types of bisphosphonates in atypical femur fracture? It may have to do with affinity for the bone. So we know that alendronate and zoledronic acid have a higher affinity to bone than risedronate and ibandronate. So it's not so much the preparation, but perhaps the affinity for the bone. We certainly, in terms of case reports, there's certainly a much larger number for alendronate, but I think that has to do with more that it has been prescribed the most, it's been around the longest, but certainly all of the 4 drugs have case reports of these type of fractures occurring.
Last question. If not, thank you all very much. Thank you for coming.
Thank you so much.
And Dr. Smith, thank you for providing justification for this celebration. Appreciate it. Thank you.
Thank you. That was very well done. This is an area that I don't know anything about. In pulmonary medicine,